are in listen-only mode.
Good morning or good afternoon, depending on where you are today. Today's webinar is being presented by Brian DeVries and Gloria Gutman, and their subject is fostering end-of-life conversations, care, and community among LGBT older Canadians. Today we'll have hopefully some time for a Q&A at the end, and it will follow their presentation. So please submit your questions online during the presentation, and we'll try to answer as many as we can. The webinar is being recorded, and it is available online on our website in red, as you can see from below, in approximately 1 to 2 days. We have a very unique situation today because Brian DeVries is in a different location and he has no control over his environment, so it's early in the morning for him, so hopefully we won't have any interruptions, but please bear with us and we'll get through it. We might not have anything happen, but just to give you the heads up. So today the presenters are Brian DeVries and Gloria Gutman, and Brian is a professor at gerontology at San Francisco State University and in a different time zone right now. He received his doctoral degree from the University of BC in '88, followed by a postdoc fellowship at both Simon Fraser University and the University of Southern California. His research interests relate to LGBT aging and trying to understand the challenges and strengths of aging as a member of sexual minority under stigmatizing conditions, the unique and pivotal roles friends play in our lives, and the role of loss in our lives. We also have Gloria Gutman today. She will be presenting the latter part of this presentation, and she is Professor Emeritus in the Gerontology Department and a Research Associate in the Gerontology Research Center at Simon Fraser University. She is also the Vice President of the International Longevity Center in Canada, and her research includes seniors housing, long-term care, health promotion, and elder abuse, among others. Gloria is also a member of our Research Management Committee here at CFN. So without ado, I will turn this over to Brian in San Francisco, and he will start his presentation.
Great, thanks, Carol. And good morning, good afternoon, everyone. Thank you for joining us to hear about this project on which Gloria and I have been working for the past couple of years, really exploring the sort of end-of-life discussions and planning amongst LGBT older Canadians. I'm assuming you can all see the slides that I'm now coordinating, and I wanted to introduce to you our research team briefly. We're, of course, Gloria and I, and aided by several really great co-investigators, some of whom we knew before, some of whom we met as a consequence of this project, and for which we're grateful, including Lean Chamberlain from University of Quebec at Montreal, Janet Fast at the University of Alberta, Jackie Gahagan from Dalhousie, Steve Mock from the University of Waterloo, and Anya Humble from Mount St. Vincent University. And as you see, we also benefited from the input of a host of really bright, talented, hardworking research assistants from across the country as well, too. Patrick Aubert, Julie Beauchamp, Jean Dumas, Robert Behringer, Kurt Furlot, Ainsley Graham Pigeon, Celeste Pang, Sarah Patterson, and Claire Robertson, and we're thankful to all of them. The project is a three-part research action national project, and we've been really excited about how it's unfolded and the direction it's taking us. It started with focus groups with LGBT older adults and service providers in 5 prominent Canadian cities: Vancouver, Edmonton, Toronto, Montreal, and Halifax, aiming to understand really issues of and extent of preparations for end of life. We also had focus groups with service providers, and the bulk of our presentation is really the results of these focus groups. Following these groups, we held town hall meetings in each of these sites as a way of relaying directly back to our participants and others some of what we've learned, and to help get the conversation started. It also provided us some guidance in a proof of concept pilot web page that we developed as a goal to have a national electronic presence that further serves to promote this dialogue and enhance preparations amongst LGBT older adults and creating a safe space really wherein that could happen. Here's the website for it, and you'll see it again at the end of the presentation. Just a bit of background of some of the unique challenges to aging experienced by LGBT persons that really so much, in my estimation, hinges on the effects of stigma, both past and present. LGBT persons have lived largely closeted lives until fairly recently, and even still there's pressures to return to the closet about which we can speak. But part of the closeted nature was that these adults, now in their 70s and 80s and beyond, during early formative years, were still seen as criminals. The Criminal Code of Canada wasn't amended until 1969, the year of the Stonewall riots in New York City. Sexual orientation was seen as a psychiatric disorder until 1973, when it was eliminated from the Diagnostic and Statistical Manual by the American Psychiatric Association. And these and so many related issues sort of precipitated a reasonable, I think, fear of accessing services from those same organizations and groups that had previously seen them as sick, ill, a threat to security. As a consequence, there's a delay in which, or an avoidance of seeking support from traditional venues, and moreover, a barrier to relationship development in a variety of ways. Marriage, as you know, for example, there was no marriage equality until in Canada now 11 years ago, and just 2 years ago in the United States. And as a consequence, I think, and as a function of the stigma, past and present, LGBT older adults are far more likely to be single, far more likely to age alone. As a consequence, are much less likely to have children. And as you keep track, those are the primary typical providers of support for older adults, and as such, LGBT people have reduced lesser access to them, and consequently more likely to rely on friends. We found in some research that 70% would rely on friends, but these are individuals who often lack the legal and social recognition of kin, and as a consequence there's awkwardness or barriers to the provision of service. And reasonably, I think, although unfortunately, there's some uncertainty as to who caregivers might be as a consequence of all of this stigma and ambiguity surrounding these relationships. And it takes place in a context of unequal protection under the law, that the safety nets around which services are provided are often predicated by traditional notions of marriage and the presence of children to provide care, and as a consequence often exclude same-sex couples. And in recent surveys done primarily in the United States, a large proportion of older LGBT adults reported that they didn't find long-term care settings safe, that they felt they couldn't be themselves or out in such settings, and as a consequence, again, less likely to access such services. And so you see the circle of these effects that influence one another, that create a context of apprehension, at least, in the provision of services. So to understand that a bit better, we conducted the focus groups that I previously described in these Canadian cities. We have 3 groups of LGBT persons, one of gay and bisexual men, one of lesbian and bisexual women, and a group of transgender persons. Early discussions with some individuals within these groups and amongst ourselves led to this division, the idea being that these groups would be safe places for people to address issues as they experience them, and we found that to be a successful strategy. The transgender group comprised both male to female and female to male transgender, have been successful even as these groups are far smaller. The requirements for participation included speaking English or French in our Quebec setting, being at least 60 years of age, living with one or more chronic conditions or providing care for someone with one or more chronic conditions, as well as some internet experience, which we use to help gauge how best to construct and support the website about which you'll hear. The contents included preparations and plans for, sorry, somehow it moved off screen. I don't know if you saw that too. Preparations and plans for care in later life, issues and concerns about aging, the role of community and the nature of support, and the role of technology in assisting LGBT persons to better prepare for later life and end of life. These discussions were audio recorded, facilitated by someone, by several of us with some significant experience in this area, and these recordings were transcribed and coded by 2 or more persons, with the results on which I'll present representative of complete agreement. The service provider groups took place in the same 5 cities. Similar requirements linguistically. We ask that they be provider services to older adults, which may be inclusive of LGBT older persons. And the focus of the groups were similar to that which I described amongst the LGBT persons, although asking in this case the extent to which these providers thought LGBT people were better prepared, the issues and concerns they thought LGBT people experienced, their perceptions of the role of support, and how technology may be engaged. And the coding was similarly engaged from these transcribed discussions. Just to give you a sense of the sample here, we ended up with a total sample of 92 LGBT persons, 40 gay and bisexual men. And we used gay and bisexual men, and the only bisexual, I believe there was one bisexual woman who was a participant. The greater presence of bisexuality was interestingly amongst the service providers. We had 29 primarily lesbian participants, 23 transgender, largely from Vancouver. We had challenges in recruitment in Edmonton, but got fair numbers in the other 3 sites of our research. The service provider sample, there were 26 divided over the 5 focus groups. 10 identified as gay, all of the men in our the service provider sample. There were 16 women in here, as I had mentioned, 4 identified as bisexual, 4 as lesbian, 7 as heterosexual, and 1 as queer, female, not trans, given the multiple ways in which individuals can identify. They averaged about 47 years of age and estimated that, well, about half of them, slightly less than half of them estimated that half or more of their clients they had identified as LGBT. So awkwardly stated, but a fair presence of LGBT persons in amongst those for whom their services were provided. We had some quantitative data that I'd like to go over just very briefly here with you. We looked at the extent to which our participants had wills, living wills, durable power of attorney, and other such planning tools. You'll see that there were about 2/3 had a will, higher amongst gay men. Almost half had a living will, higher amongst lesbians and gay men, and fairly common representation of power of attorney. Lesbians were more likely to have a representation agreement, and for those who are joining us from outside of Canada, that's a more unique feature. From what I understand, that sort of lists the partner in a much more formal way. About 1/3 of the gay men had prepaid funeral arrangements, far greater than representatives of either the lesbian or the trans. Very few had long-term care insurance or critical care insurance. Again, this, as a Canadian sample, that might speak to some of those issues. About 1/4 had made informal caregiving arrangements, higher amongst gay men again. and about 3/4 had reported explicit care discussions, and just a smaller percentage explicit end-of-life discussions. So these quantitative data, at least those with the high endorsement, appear sort of pleasing to suggest that there is preparation happening, and I don't want to diminish that and believe these to be true. But as you'll see in the discussions and the results of our focus group analyses, that notwithstanding these high percentage of explicit care discussions, that there isn't a lot of focus on the specifics that really need to be addressed in order for care to be forthcoming. I'll share more of that with you. Again, just to give a little bit of the demographics of our sample, the largest proportion lived alone. It was 62% of gay men, 70% of trans, just slightly less than half of lesbians, were single. 72% lived alone. About half of lesbians and transgender persons lived alone. Over 3/4 of gay men did not have children. About half of lesbians and 1/3 of the transgender population did. And across the board, about 1/3 said they had not identified a caregiver. So again, as we review the constituents of the likely providers of care being in a more heteronormative way, spouses, partners, adult children, as so many other studies have found that the presence of these potential care providers are lesser amongst those identified by the LGBT people in our samples. So to get to the meat, really, of our data, the focus group discussions, I mentioned that they were recorded and transcribed, in part aided by a system one of our research colleagues brought to us, MaxQDA, not exclusively. So we also used improvised and more standard content coding procedures. There were at least 2 coders who read through all of these hundreds of pages of transcripts. When there were discrepancies, they were resolved through discussion. And we started with codable units or phrases clustered into categories, further clustered into 7 overarching themes, which I'll now present, which include end-of-life preparation, relationship challenges, concerns specific to the LGBT population, institutional concerns, caregiving experiences, financial issues, and trust and honesty. So if we look at end-of-life preparation as the prominent overarching theme, we'll see that amongst the gay men, lesbians, and transgender respondents, all spoke of having completed formal documents in a variety of ways and with a variety of issues, and the discussions they encountered initiating and engaging in end-of-life, about end-of-life issues. So there's consistency in the endorsement where there are interesting differences in the ways in which these issues were discussed. Not across the groups, but often that's the case. For example, all spoke of a range of having completed discussions from, yes, I'm just thinking about it, to they are complete. They all spoke of push factors into these discussions. Gay men mostly noted being shocked into planning by the death of a friend. Lesbians and transgender persons more likely being pushed into it through their own personal health crisis. Transgender people uniquely said that they were lesser prepared, in part because the necessities of life take priority. It's as if such document completion was itself a sort of luxury, having already resolved the other daily demands of everyday life. The end-of-life discussion challenges included across the board an articulation of there is no one to whom to turn. And that itself is a poignant, somewhat common finding that really speaks to the nature of this population and the challenges in preparations. Gay men would say they have few conversations, and if they are, they're often general, along the lines in a joking kind of way, well, pull the plug if I ever get that way. Lesbians, too, said they had general conversations, but the generality they reported was sometimes related to modesty, not wanting to ask for such support or concern about how others might respond. When there were such discussions, they were mostly partner-based and contingent upon each other being present. Transgender persons similarly were more likely to have had general discussions, and said that they don't really have the appropriate language for such conversations. Here and over the next slide, you'll see that notwithstanding how LGBT persons spoke of similar issues, that the lesbian, gay, and transgender persons all address them in often unique ways. And that's, I think, a really important finding from our research. The relationship challenges implicit in some of what has gone before included ambivalent family ties, which is strongly endorsed across the group. Gay men said, we lost our families when we came out. Many, however, spoke of siblings as potential providers of care, even as, when pushed, they had not yet talked to those siblings. Lesbians said similarly that they had challenged relationships with their families, one of whom said their family considers her extraterrestrial. And when families were mentioned, often it was in the context of children. Transgender people similarly said, my family can't accept me, and further noted that partners are rare in the trans community, stating a sort of general feature that renders family ties ambivalent. The strength and challenges of friendship were mentioned by all of the groups. Gay men spoke of chosen families, as did lesbians, and interestingly less true of transgender participants. Gay men made reference to the years of AIDS and said, we will be there, as we did before. As well, but more prominent amongst the lesbian discussions were comments, well, friends have their own lives and I don't want to intrude on that. Transgender people said the trans community could come together out of necessity, in part feeling like nobody else would be there. All groups also spoke of loneliness and isolation, more so amongst the gay men and transgender populations. The gay men spoke of their AIDS-related aloneness, one man poignantly saying that he's out of practice with his grief, having experienced so much grief in the late 80s and 90s, less so in the intervening years, and now confronting it once again. Transgender people spoke of being old and trans and as a consequence lonely, and having to live a secret life that led to a solitary existence. The groups also mentioned LGBT-specific concerns, and here's the first of a couple slides, one of which is the dynamics of LGBT culture, of which ageism figures prominently. Gay men saying that they live in a pickup culture that puts them more on the sidelines. Lesbians saying that they're often avoided by young lesbians, and often in more public settings, it's a world of gay men. And transgender people spoke of how the community really embraces aging, and spoke as previewing some of the discrepancies or some of the conflicts within the community, saying that gay people just don't get trans, and that even within the trans population there's divisions of post-op versus non-op, meaning before the surgery or avoiding or not having the surgery. There were issues of disclosure that were across the board, albeit in different kinds of ways. Gay men spoke of having to live two lives, one open, one closed, and as a consequence, compartmentalized existence. Compartmentalization really has implications for accessing the support networks if, in these compartmentalized domains, not everybody knows everybody else. How is it we would gather a group together to provide support? Lesbians spoke of not being sure what to reveal in medical situations, and even suggesting that identification as a lesbian is still taboo. Trans, on the other hand, said that it's impossible not to come out as trans in the medical environment. and the consequence of living a secret outside of that reduces the quality of life. The role and history of HIV was apparent in the discussions of gay men especially, and somewhat amongst lesbians. But gay men in all of the groups, they made mention of how their approach to end of life is colored by the many losses they endured, saying that they never expected to live this long, and that the urgency has gone away, so the extent to which they can call upon networks and others certainly isn't as it was during the time of AIDS, and they often made reference to that. Lesbians, although mentioning it less frequently, spoke of the responsiveness of the community at the time of AIDS and how there is that history there, and also commented on the significant contributions of women, further saying that those contributions were often not reciprocated. An LGBT-specific concern and specific to the trans population had to do with gender affirmation surgery, and transgender people spoke of having the surgery really poignantly to prevent abuse in long-term care. That is, don't want people looking at me for interest, and as a consequence, a motivation to have surgery. Institutional concerns were mentioned, including barriers to social and health services, primarily how rare LGBT affirmative services are and the extent to which they have not felt welcomed in such services. Transgender people pointed to the profound heteronormativity of healthcare institutions and how that served as a block for them. All the groups spoke of political action and advocacy, which was really powerful to hear. Gay men said we need to educate younger people, we need to advocate for ourselves. Lesbians, in a much more profound and strong way, said others need to hear a history, and specifically called out the government, saying it's our employee, it should do its job, and it isn't. Transgender said we need people to help speak for us when we can't, and we can't often when we're ill, and we need education that has to be bottom-up, relevant, and lifelong. Not top-down, not episodic. Interestingly, a couple of the groups mentioned the role of church. This came primarily from two of the settings. One saying that church offers some community, but it's a sort of guarded community in that they were also concerned that being gay, in this case, could be used against them to serve as a barrier to accessing that community. And we heard from a couple of lesbians in a couple of the groups that church life was a part of them and they couldn't eschew it even if they didn't feel welcomed therein. The groups also mentioned their vast caregiving experiences, primarily gay men and lesbians. Interestingly, there was frequent mention of parent care on the part of gay men, also for lesbians, but more husband and sibling care for lesbians, and a lot of mention, of course, of HIV/AIDS caregiving and the parallels that were drawn, some of which I've already addressed. Gay men spoke of the lines in the sand that they would create around caregiving, and changing diapers crossed that line. And interestingly, lesbians exclusively spoke that caregiving need not be only a negative experience, that there can be unexpected joys and comfort provided from caregiving. Lesbians and trans, but not gay men, spoke of financial concerns. Lesbians addressed it often in terms of class issues and resources lacking for lesbians that exist for gay men, as well as some of their employment history. Transgender persons spoke of the two-tiered system around resources that really divided those who can have the surgery and those who could not, and mentioned also unemployment, underemployment, and homelessness in ways that the other groups did not. Trust and honesty were mentioned by the trans and the gay groups. The gay men spoke of an absence of trust and honesty that was really a key to how a relationship might be perceived. And in several groups expressed concern of being screwed over by others when care is needed, particularly around wills and money. Transgender people spoke of a generalized lack of trust owing in part to their healthcare experiences and having to rely on others and having been failed in those efforts. So in summary of the LGBT groups, you see many similarities in terms of the key issues that are addressed and important differences in how they're addressed. And I think that's a really profound finding, that in a scalar approach, even as many would agree with the issues, finding little difference perhaps between them, in this more narrative approach, even as there's some general agreement about the issues, the manifestations of those issues and their endorsement vary significantly. Let me quickly go through the service provider group and then hand it over to Gloria to talk about the next steps. The service provider themes, they're grouped into primary and secondary, and few differences across sites, and so they're grouped by themes themselves with the sites aggregated here. And one primary theme is the importance of the community to its members, and service providers felt like, and reasonably so, LGBT people wanted to be recognized as a whole person and needed a space, and the community could help provide that if only these services could work well with the community. They spoke of some of the caregiving challenges, addressing the horizontal care structures amongst LGBT persons in contrast to the vertical structures amongst heterosexuals, meaning, as you might suggest, that caregiving more amongst equals, men and women of comparable age and socioeconomic status, amongst LGBT people versus the generational care provision of heterosexuals. They addressed the loneliness and isolation, much as the LGBT respondents did, speaking poignantly of the kin abandonment and the superficial family ties. They spoke of the healthcare environment not being LGBT affirmative, even as you saw that roughly, well, certainly more than half of our providers were themselves LGBT, and as a consequence, they articulated the risk of re-traumatization and shaming of LGBT people as they sought services or in the way in which services could be provided, and the need to communicate to the community that this is an inclusive place and how it has to go beyond the flag. They spoke of general end-of-life discomfort, that all of this is taking place in a culture that doesn't like to talk about death, end of life anyway, and so we have a particular group in a broader context with barriers to all in having effective conversations. They addressed the legacy of HIV, as did gay men and lesbians in the groups that I shared, including compassion fatigue and a recognition of aging with HIV and all that that's entailed. The additional comorbidities, and our colleague Mark Brennan-Ing has done extensive research on this, finding an average of 3 more comorbidities amongst people with HIV. They spoke of aging and cohort experiences, really representing a pretty coherent and clear view on the communities that they're serving. Saying the queer community is ageism on steroids, for example, that if we see ageism more generally, we see it even more so primarily amongst gay men. And a group saying that everybody worries about the queer kid, the puppies and the kittens, the cute ones. Older LGBT persons are better off to be submerged, and so that they lack the status in the esteem that's afforded even within the community, and LGBT aging falls to the bottom there. They spoke of appropriately a lack of data, which in the US we're starting now to finally adapt through changes of Health and Human Services. We don't have correct and focused data, and often funders require that. They mentioned the role of HIV itself, as well as in addition to caregiving, and much as lesbians did in the focus group, spoke of the ineffective government response, that equal does not mean equitable, and the government is more reactive than proactive. But they also, interestingly and I think importantly, spoke of the resilience of the LGBT community, of how the community itself has risen to so many of the challenges. This resident-initiated changes in the assisted living from some of our respondents, LGBT people standing up for and advocating for themselves, service providers responding to such actions, and interestingly spoke of the diversity within the LGBT community, something that these data point to, but it's often lacking in the overall patterns. There was a quick tour of these really rich data. Let me use this opportunity now to hand it over to my colleague Gloria to describe some of the steps we've taken with this as a base. Gloria?
Thank you. We had, right from the beginning, thought that we wanted this to be more than just research. And so that we had in mind that we would develop a pilot website that would provide, amongst other things, an opportunity for people who wanted to dialogue with one another in terms of building some community and talking about these issues that are so hard to talk about. But very early on, in the focus groups, people started to talk about the need to know about what was out there, what resources were available. So if we could have the next slide. Brian, next slide.
There we go. Thank you.
So very early on, so what we did, based on what we heard from the Vancouver focus group, which was the first, those were the first set, we developed the British Columbia LGBT end-of-life resource inventory. And this has a listing of a number of different facilities and services available for people who want to do some end-of-life planning. And it includes everything from some healthcare services to getting your will done to funeral arrangements. And we also heard from the people we talked to in the focus groups that they wanted to know the extent to which these particular services were in fact LGBT friendly. So each of them that are listed in our inventory, and this inventory became a model because we ended up doing one for each of the 5 places in which we had done our focus groups. But the actual, if you go and look at the inventories, you'll see that the items are classified as being an LGBT organization. That so the service was developed or is provided by an LGBT group. The second classification would be what we call LGBT-friendly formal, where it's clear on the website or in their documents or mission statements that in fact they are welcoming to LGBT persons. And the third classification would be those that are informal. They talk about or other people talk about the services being LGBT friendly, but it's not as explicit. So as I said, this was a model. If you go to our website, you will find that you can download these resource inventories. We update them on a quarterly basis. So these are living documents. Next slide, please. This is a screenshot of our LGBT website, our end-of-life. We call it the End-of-Life Conversations website, and it has a number of sections. There's a section, the About Us talks about the research team. The activities talk about the various presentations, and actually we have posted a number of the PowerPoints and videos from the presentations we've done over the last 2 years. We have the resource inventories. We have a unique section called Conversations with Robert, where the webmaster did interviews with Brian and with me and addressing some of the key issues that came up in the focus groups. We post some of the recent news items, we have a calendar of events, and we have in there a discussion forum. Now, one of the things that doesn't show on this particular screenshot is that we have a page that is devoted to elder abuse in the LGBT community. And that came relatively late in the development of the website, and it was as a result of a grant that I subsequently got after the one from the Canadian Frailty Network. It was from the a BC government agency, and where we have developed resources specifically for elder abuse in the LGBT community. Next slide, please. Brian, next slide.
Yep.
The one, you skipped one. Can you go back one slide? We've actually found that we've had quite a lot of traffic to the website. As you can see, in the first 16 months, over 7,000 people visited it. The 9 videos that are posted on it, and those are the conversations with Robert, have been seen over 2,100 times. We were surprised that the discussion forum was not used very frequently. It was only in the first little while. And what we've subsequently found out is that a number of organizations are experiencing the same thing. That now with Twitter, with Facebook, with ways when people can have instant contact with one another, they're less likely to use these kinds of chat rooms or moderated kinds of web means of communication. So if we can go to the next slide, which is the policy implications, what comes out loud and clear out of this research and our experience in taking the findings to town halls and feeding back to the people in the community, mixing people, the service providers and consumers, is that one size will not fit all. And it's really important to recognize the differences that exist within the LGBT community. There are issues some that are common, but there are others that are quite different for gay men, lesbians, and trans people. So we need to recognize the difference. We need to recognize the legacy of HIV, particularly as it impacted on gay men. We need to recognize that there is differential access to resources, that within gay men, the lesbian community or the trans community, there are some tall people, there are some short people, there are some who have better economic resources or better social connections than others. And very definitely that it is very difficult to be a trans person. I think they are about the bravest people I've ever met. We need to be concerned and to lobby for and on behalf of greater inclusivity. In general, healthcare settings tend to be heteronormative. We need to educate all levels of staff, from primary care physicians to long-term care to hospitals and hospices. And we need to foster and facilitate advanced planning. We were surprised that they had done as much planning as they had done. In general, older adults do not do a lot of advanced planning. And the same is true of the LGBT community. As Brian said, there was about a third of them who could not identify who they would contact in the event of needing care. And so we need to also think about similarities and differences and lessons that can be learned from this research and its application to other marginalized groups. And in particular, very early on in our project, we were getting complaints that we had only done our focus groups in urban settings and recognized, and we're urged to recognize that some of the issues of LGBT people living in rural communities may be different. So that's basically, it was probably one of the most exciting projects I've worked in my long career as a gerontologist. And we want to acknowledge the support that was provided by the Canadian Frailty Network, and who gave us a Catalyst grant. And Brian, if we could have the last slide. If you want more information, you can contact me or Brian. Brian is an adjunct professor at SFU, as well as having his primary appointment at San Francisco State. And so the home of the project was the SFU Gerontology Research Center, and please do visit our website. There's lots of really good resources there. Now we'll turn it back to Carol.
Thanks, Gloria and Brian, for your very informative presentation. You presented a lot of information for us to absorb. The next step is we probably have about 10 minutes to do some questions, and so I will start that, and you can choose which one of you wish to answer the question or both. One easy one basically is, has there been further work done with the non-English French speakers? I'm not sure if you know of all the research that's been done out there, but
with our data, they've been translated and included, but we do know that one of our colleagues, Lean Chamberlain, for example, I believe has recently received a grant and had been very well known in the area of LGBT health and well-being and LGBT aging, has done quite a bit of work, community-based work in that, along with the colleague also from Montreal. So there is a fair bit, I think, that largely originates, I believe, with Lean's work is prominent in that. Lean Chamberlain.
okay. So given that other people are working on different language projects, is there any other research that you think needs to be done in this area?
Well, as we said, certainly the issue of older LGBT people who are aging in rural and remote settings, and to make it possible for them to get greater access than they currently have to resources. And so that was one of the pieces, the motivators for wanting to do the website. And I should mention that we have a commitment from Simon Fraser University Gerontology Center to have that website continue into perpetuity. And we have a webmaster who has agreed to stay on that job until he finishes his PhD degree, and he's just beginning.
Excellent.
And
Good to hear.
And I think that as is true generally in the field, we know very little about LGBT people of color. And so I think so many of our samples tend to be Caucasian, and we know very little about Aboriginal or First Nation LGBT people, or LGBT people from India, or any other number of ethnic backgrounds. And so it would be really interesting to be able to make some statements that are more inclusive, or to be able to compare across these diverse cultural backgrounds. And we just either have not had the data, or, and I honestly believe, I don't think the attention has been there, although that is shifting. I think there is a real move to try and have broader representation and comparison.
Yeah, and that again speaks to the diversity within the LGBT community itself.
Right.
And that's one of the questions that just has come up is, you know, have you considered First Nations and all of that, you know, all those populations, and it sounds like there's a lot more work to be done. Are you both interested in continuing in this area?
Yeah,
Well, it's Brian's primary area, and most definitely, yes, I have found this to be an interesting group to work with.
You know, here in San Francisco, we tried to do a citywide survey 3 years ago, and with real intentional, significant efforts to include people of color. And so we had a survey that was ultimately completed by over 600 people, LGBT people 60 and older. And we had it translated, it appeared in 5 languages. We had community groups on active in its design and implementations, with members in the group in their communities trying to encourage participation either online or by paper. We use different terms so as not to exclude individuals by calling it LGBT, so it had same-sex attraction or any number of other terms. And even still, we got really modest participation, even in San Francisco, amongst people of color. So the outreach to these groups, the terms we use, there's so much work that needs to be done, and perhaps a lot of suspicion on the part of participating in it, but we're not very far along there at all, and much needs to be done.
Go ahead, Gloria.
Yeah, in my project dealing with elder abuse, we did a couple of town halls with service providers in the Chinese community and in the Punjabi community, and in both cases we were told, so we had, with this project and with the second one, we have a lot of community partners, and so we would bounce, you know, anything we were planning to do that would have an interface with real people out there off the community partners. And we were told that, you know, you have to phrase it differently, because in some of the ethnic communities, they don't recognize words like lesbian or gay or trans. And so you have to use and approach the topic in a different way. So this need for sensitivity is even greater than when you're dealing with the general population of older adult LGBT people.
Okay. Yeah, so there's lots of work to be done. We've got a ton of questions coming in, and I know we can't get to all of them, but here's a final question to wrap it up today. And I know that both Gloria and Brian have left their email, so maybe you can connect with them later. But Tim is asking how we can get a similar program with the same information for national information in the USA.
For national
information?
Well, if people go to our website, they will find that, in fact, you know, we started out with the idea all we'd be able to do was a pilot and that it would be BC based, but it's not. It ended up being national, and it has international links as well. And we're finding that people from around the world are actually accessing that particular website. So this was a national project. We have we've looked at the data and compared across the different regions, and in fact there are not a lot of regional differences. The differences were greater between gays, lesbians, and trans than they were geographic differences.
And you know, I like how Tim is thinking, and would love to see something similar. You know, there SAGE in Services and Advocacy for GLBT Elders out of New York, but now I think there's 34 satellite programs or offices, for lack of a better word, across across the U.S., and they seem like a natural for this. There also is the LGBT Aging Resource Center online that SAGE facilitates as well, with the funding initially from, I believe, Health and Human Services. But it seems like that SAGE and this National Resource Center are the likely partners for something along these lines, to which we would be more than happy to offer whatever we can. And I'd be very excited to see this have a presence, a bigger presence in the U.S. and elsewhere.
Okay, perfect. I think you're getting lots of kudos from our audience today, and thanking you for the presentation, and knowing that there's lots of work to do and that they should head to your website. So we'll put that on our website as well. And so thank you for your presentation today, and hopefully we'll see you back here again. Just a quick brief survey will come up on your screen. If you have a minute, can you just provide us with a response? It helps us improve our webinars going forward. And just to indicate, you see the 2 upcoming webinars. You see James Downer from U of T will be doing the pilot study of medication rationalization intervention, and Franz Lagarre doing the improved decision making involving frail elderly and caregivers on location of care. So, and in red you'll see where the webinar slides and the video will be available in the next day or 2, and on those slides you'll see both the contact information for Gloria and Brian and their email, as well as their website. And so you can visit that, or please feel free to email us at the info at, and we can pass that along to you. So thanks for coming on today, and we hope to see you next time as well. And again, thanks Gloria and Brian. I know Brian, you're off rushing to another event. So with that, I'll say good day and thanks for joining us. Bye-bye.
Thank you.